folks, thanks for coming here. I want to make my conversation with you guys brief and hopefully helpful to you. So I got 5 minutes, and I probably won't even take that amount of time with you. So my name is Peter Regis. I'm with Cyber MDX. Our company focuses on healthcare in general, and with the specialty in hospitals. And what we try to do is we do a number of different things, but really for the folks that have to manage, maintain, locate medical devices, whether they're infusion pumps, CT, MRI machines, anything that's a medical device or its ecosystem, we help you both identify those on an automated basis. So anything that's connected to the network that will happen to move around, if it's an infusion pump, if it's any kind of mobile card, we'll tell you what that device is, where it sits on the network, what its current status is, make, model, serial number, current operating system, OS, etc. And we'll tell you if that device is in use or out of use. So we give you a holistic view of those devices. Now, a lot of healthcare systems try to track that stuff manually. So at a base level, we automate what is otherwise a tedious, time-consuming task of where is this infusion pump, what software is it running, does it have a particular vulnerability that just got announced, or there was an FDA recall on some of these devices, which ones are affected by that. So we automatically map all of that for you. And in addition, we tell you, we give you an up-to-date inventory of where these devices are. So if they're moving between facilities, if they're not connected when we first saw it, where we last saw it, like what part of the building it's connected in. If it's wireless, we can tell you what access point it's connected to. If it's connected to an Ethernet switch, we can tell you, what part of the building or what floor that switch is on, so you can have an idea of where these medical devices are connected to, right? So what we do is we put a sensor in the network itself, and it just listens to the traffic. So we don't actually have to put any software on these devices, which are generally, it's not allowed because they're FDA regulated. And we also just do this passively by just listening to the traffic and building out the profile. We have a very sophisticated system, but it's a very easy implementation. But in terms of how this technology helps the folks that usually manage and run biomed devices, is that it tells you what's there, how many there are, where they are, what their current status is, if there's a vulnerability associated with it. We track, like I said, FDA recalls on these devices themselves, and we'll give you a sense for the security posture of these devices. So the security team has a different view of these as well, so they'll get a full-blown security analysis or vulnerability assessment for the endpoint itself. As you try to secure medical devices, the issue today, just to give you guys a little bit of background, for medical devices, that they're generally not visible to the IT team on the network. They can see what's typically an IP address and a MAC address, but that doesn't tell them what that device is. A lot of imaging machines will run on Windows machines, but that's not necessarily a Windows workstation, right? It's an imaging machine, and so it's handled differently in terms of how you manage that device on the network itself. So this helps you both understand those devices and secure them, because the first step in understanding what's on your network, and then the second piece of that is helping secure those devices on the network, so that you are not having unnecessary communication to those devices. From a cyber perspective, we limit what's called the attack surface to restrict access to those devices, make sure they're not communicating in a way, and increasing, what's ultimately patient safety and then operational productivity for the hospital itself, so that folks that usually manage those devices aren't spending their time doing the tedious, time-consuming tasks of inventorying these devices, understanding where they are, and they can focus on maintaining them, limiting the cyber risk on these devices, and really just improving the overall hospital experience for everybody that's in there. So, we have a table in the back. If you guys wanted to drop by and take a look at what we've got, we have a full demo system. We can show you what it can do specifically for, for folks in biomed or clinical engineering, and we're happy to show that to you. So, thanks again for your time here. Hopefully that was.
Well, if you stick around, you're going to hear about that in my presentation.
All right, excellent.
So, we do fund the HPM department funds that tool we use in our company, and it's we have it integrated to our NAC as well. Yep. So
awesome.
I'll talk a little bit about that in my presentation, but that's the value add that we provide for our employer in our facilities. Right there. But yeah, you should go visit if you're not familiar. with these types of products, you should go visit CyberMDX because you should have a tool like that at your disposal because it does give you a tremendous amount of information. But we'll talk a little bit about that in my presentation today. We're good at it? All right, Megan. Thank you. Thank you for coming to my presentation today, and thanks to CyberMDX for the sponsorship. My name is Chris Nowak. I work for a company called Universal Health Services. We are one of the for-profit health providers in the country. We're based out of King of Prussia, Pennsylvania. On the acute care side, we have about 6,400 beds in our system. We also have a behavioral health business that's the same size as the acute care business. We have almost 500 behavioral health facilities in the United States. UK, we have about 220 or so facilities, and then a few in the Caribbean as well. So very large footprint that we take care of. On the BH side, the HDM department, we do a little bit of PM work on some of our larger facilities. We do have some large inpatient behavioral health facilities around the country. We do some PM work in those facilities, but for the most part, at the smaller BH facilities, we'll put the device in a box and ship it to one of 3 depots for repair, and then we ship it back to them. It's just more cost efficient. We turn it around very quickly for them. So that's a little bit about me and about what we do. We have 28 acute care hospitals around the country. So 5 east of the Mississippi and the rest are west of Mississippi. A lot in Las Vegas. We have 6 hospitals right in the Las Vegas area, and then several in the Texas area. But anyway, so much for the clicker. Let's see. How's that? No? Uh-oh. What's that, buddy? Yeah, I do. Let's see. Why is that? What's that? I am. Sure. Oh, there we go. Cool. We're gonna get this off of here though. Come on. I can't get the mouse up there. Yeah. Oh, thank you. Okay.
Okay, see if you can advance up.
Perfect. There we go. All right. So my goal today in this presentation is that you walk away here with some nugget of my presentation. I don't expect you to memorize a lot of the presentation, but I just want you to walk away with something that you can bring back to your facility, your company, and put it into practice, save money, make it safer for the patient. That's my goal today. So my presentation is about COVID. Some of the things that we learned in the COVID situation and how to deliver value to your employer. So SEMPER PARATUS is the motto of the United States Coast Guard, always ready. So we as HTM professionals should be always ready because this time it was COVID, it's going to be another time. And it was a struggle, especially early on, with regard to the demands placed on me and my team, mostly surrounding medical devices that are mobile. So the ventilators, the infusion pumps, patient monitors. We were setting up temporary units in our hospitals, locations within the hospital, conference rooms. We were setting them up as ICUs. So a lot of logistics and a lot of things that go along with that, and you need to be ready for those things to happen again. But The biggest thing was how to maintain regulatory compliance, because we really didn't have a waiver from CMS for quite some time, right? Goodness gracious, I think it was sometime at the end of March before we saw a waiver come out from CMS that allowed legally us to kind of miss that 100% compliance with planned maintenance. Now, we did okay through our planned maintenance program. I did have one or two hospitals because we did have some furloughs. We had reduced hours in some locations. So those locations where there was no surge, there was nothing going on from a COVID perspective, you know, so the hospital has stopped elective surgeries. Most of these states prevented elective surgeries from being done. PPE, you know, was a big focus. So, goodness gracious, we had a 300-bed hospital that had, you know, 60 patients in. And there was no reason to keep full staff. There were furloughs, reduction in staff hours. So that caused some problems in getting planned maintenance completed on time. Fashion. Plus, we had a couple of vendors that also refused to come in, and we'll talk a little bit about that later. I'm sure some of you may have had that experience as well. One of those surgical robot companies that is very popular was one of them. So, from a regulatory compliance perspective, I think one of the things that helped us was our AEM program. If you're not doing AEM, it is such an important piece of the puzzle for your program to have the strategy. I just looked at our data this morning before I came over. We're 59.4% of our devices in the we have 118,000 devices. We're 59.4% of those devices are on our AEM strategy. So 60% of the devices are on an AEM strategy. And I was just in the first presentation with Matt Heritage and Carol Davis Smith, and you know, Matt put up on the slide, the AEM program allows you to lower your PM costs. Well, you know, with our APM program, that really isn't, that wasn't our focus. That wasn't even our strategy for implementing the APM program. It was a very fortunate, very positive consequence of our APM program, but that certainly wasn't why we wanted to go down the APM route. The reason why we wanted to go down the APM route, because we all know, I'm sure some of you know, you're doing planned maintenance, and the benefit of the planned maintenance is suspect, right? We're going through the motions, we're doing planned maintenance on medical devices, and we're following the manufacturer's specifications. Each step we're following, I can recall maybe 10 or 15 years ago, I had a very intelligent, very well-degreed, lots of pedigree engineer that was fixing my infusion pumps. And, you know, goodness, he did meticulous work. It was a beautiful thing. And I walked over to Greg one day, and I said, I watched him. He's going through the motions. And I said, now, Greg, when you do that test, have you ever seen that fail? Have you ever seen that process? Oh, no, it's never. It wants to be there. And and you know, that was a big deal. Oh my gosh, we can't skip that process and save time. It would take him maybe 2 or 3 hours to turn the infusion pump around for a PM. He was literally remanufacturing the infusion pump. It's a beautiful thing. It looked great, but was it effective in our program? And did it add any value to the safety for the patient? Started to take a hard look at that, you know, and really understand. Of course, initially, I was going to kill me. You know, he finally understood, my goodness, I can become a whole lot more efficient by, instead of having a 55-step procedure to do the PM on the infusion pump, I can cut that down to 37. And I could save a significant amount of So the AEM program is fantastic for us to utilize, and probably a very valuable aspect to your program that you're using or should be using. I'm going to mention the next thing is the right to repair. So from a regulatory compliance perspective, the reason why I spent it here, and I did that again toward the latter part of my presentation. But the right to repair, I mentioned, we did have a few vendors that refused to come into our facility. I think mostly it was in the surgery area. A couple of them were in the surgery area. The first time the vendor came in and said, no, or called and said, no, I'm not going to do plant maintenance. My team did plant maintenance. What's the problem? So that was, I was really surprised by that. So the right to repair is such an important thing. I hope you're engaged in, because the OEMs really want to hold on to that piece of financial gain. A lot of margin involved in it, and they really want to hold on to that. And they're creating a lot of patient discontent for third parties, for in-house programs, and you'd be surprised at some of those organizations that are involved. They really play both sides of the fence. Some of them have their own third-party biomedical companies, while they're also manufacturing medical devices. So the right to repair is an important thing you need to be engaged with, especially in your state, at the corporate headquarters where in Pennsylvania there's a lot of activity in my state going through that, and a lot of activity in other states as well regarding the right to repair. Because it not only impacts HCM, the HCM career field, it's your tractor repair company. Your John Deere, if you're in a rural community, the guy down the street that fixes John Deere equipment, it's not a John Deere deal. It's your automobile, when you take your car for repair to the local gas station, not the Ford dealer, Mercedes-Benz dealer. So it spans a lot, and this legislation can be very impactful to our career. And David, you give us a talk a little bit about this? Three. So I encourage you to go take a visit with Dave's meeting. So the next piece I'm going to talk about is risk. I'm going to have a slide on that. Vendor relationships became so important during the COVID crisis. What do I mean by that? Well, if you're renting equipment and you became in dire need of certain devices, and you went to rental companies that you didn't do business with, a lot of times it was a challenge because they didn't have a history with you. They had other customers they were going to take care of. Medical device sourcing, that is even on the OEM side. Medical device recalls, we were caught up in that whole BD. We're a BD, Alaris, Fusion Infusion Pump organization. And that pump is so woven into our organization. We're a server house. And through server, we have an automatic pump program. So in a pharmacy where a physician puts an order in for a drug that needs to be infused, the order goes into our pharmacy. The pharmacy prepares the bag upstairs. The bag goes up to our Pyxis machine. Once the nurse, the caregiver picks up the bag out, Pyxis and hangs the bag, scans the patient ID, scans the bag, the pump is automatically programmed for whatever that physician put on the prescription. So we couldn't go and source big bronze pumps and think we could just help our fleet out by using another pump manufacturer. We don't want to do that. So that BD recall has certainly been impactful for us through the COVID crisis as well. You just told this gentleman from CyberMDX speak about cybersecurity. I'll talk about that. And then, of course, I just talked about some of the furloughs and cut hours and hospital margins. And the last thing I want to talk about is the value proposition. talking the talk to your administration. So regulatory compliance, we should all have a daily, yes, sir.
I just wanted to mention that you mentioned about relationships. At the same time, what I saw, at my hospital was in the hospital relationships. In particular, when we had a shortage of ventilators, different hospitals had different type of patients. We were able to borrow from other hospitals. For example, we were able to borrow from children's hospital, which had no patients. So I saw that relationship.
Yeah, fantastic point. As I mentioned, we have 28 acute care hospitals across the country, and we went out shipping built B60s across the country, infusion pumps across the country, some monitors across the country from our own. But you're talking about local relationships as well.
Yes. Can you maybe talk a little bit more on how your facilities management PPE costs?
So what we have done, obviously we have to wait for that. Software, we're up on the 9.3 version of software. There's nothing we can do about that. We manage the risk in it. So every one of our nurses and they're aware. One of the things we have in our organization is the communication platform. So that information gets out to our frontline nurses about the risks associated with what to look for as part of that being recall. We also, very early on in the COVID crisis, we started going out to the vendors like USAC and Pacific Medical Delaware, Select up in Minnesota, and buying infusion devices, brains, pumps, the 8100s. So we went early on and tried to buy as much in US Medical as well as one of them. We tried to buy up as much as we could, but as time went on, it became more and more difficult because everybody caught on to that and started buying as well. So the 8100, I cannot find the 8100 pump in the third-party market to buy. So that's the way we managed to recall. We had we buy our plastics from somebody else. We buy our plastics from me and things like that. So we don't rely on a BA or a lot of that. We get the sensors. We buy that from several ones. So it's a third party. Your buyer sells cables. There's rather than the OEM trying to source as much as we can to third party organizations. But typically they're more responsive. It's just a better overall purchasing experience. So at least that's what we have done. I hope that helps you out. So it's time to talk about the daily focus on plan maintenance. You might see we do have daily focus. We have a dashboard. If you'll see in the next slide, we have a dashboard. We have a big screen TV in every one of our departments across the country, and it's specific to that facility what the dashboard looks like. So there might be certain things that need to be focused on depending on the facility, depending on what the product line, the big product line is, cardiac product line, or the big product line. There may be different focuses. So your dashboard may look different, but it all comes from the same database. So knowing your plan maintenance schedule is so important. Your staff needs to know it as well, not just the director, the manager. The staff needs to understand because they're going to help you with buying parts and pieces, batteries, schedule infusion pump PMs. Some of our hospitals have 8,900, 8,100 infusion pumps and 700 brains. So you got to have don't order your batteries over the phone. It should be very expensive. So knowing your planned maintenance schedule and what's coming up is an important piece. So knowing your planned maintenance schedule is important. See, and that's the return on the investment. planning ahead, getting the parts ahead of time, so that your staff isn't scrambling and you're ordering things overnight. I did put a little, I glossed over it a little bit, teamwork. So even if you're a one-person shop, you know, I know UC Health has some small critical access hospitals. We have a couple of those as well, where actually one facility, they only staff it 2 or 3 days a week, they only staff it full time. So when it comes time for plant maintenance, teamwork is so important. Getting the nurses to understand. One of the things that we do in our program, I don't use stickers. There's no PM stickers on any of my equipment. The only sticker on my equipment is the inventory control sticker. That is the barcoded number that we use to identify an active device in our system. So, because this is my whole rationale. This is how, because of course, when I came to UHS and I suggested this, they thought it was crazy. They thought the whole world was going to fall down. But my point to the CNO, corporate CNO, as well as some of the other CNO, especially California, it was, hey, look, I want your nurses to do patient care, not equipment care. That's our job. If your nurse has to worry about if that plant maintenance is getting done on that device, it's a bigger problem than your nurse discovering that one of my team members isn't getting the PM work done. Okay, so I didn't want to figure for that reason. The other thing, it allows me to change schedules, right? I have a very robust ADM program. If I want to change a specific frequency and I have stickers, I have to go, I have to find one of those devices. I have to throw another sticker on now with a new strategy, because it's a different timeline. I can change the timeline. I don't have to do that anymore. If I want to change the frequency based upon the data in my database, where I want to either increase the frequency or decrease the frequency, I can do that very, very easily. And I don't have to go around and gather up all these, like, the labor involved in doing that, especially if you're doing it on the fusion bomb or a sequential compression device or something like that. Goodness gracious, it drives us crazy to waste all that time. So we don't use stickers. So, however, you might be thinking, wait, why is a joint commission survey perspective? How the heck do you get around that, fella? So my CMS database has access to it. The nurse has access to it. In fact, my finance group uses our database for the asset management piece of it. They go in and they can find out any assets, the install date, PO number, all that great stuff. The nurse has that. Now, the nurse, their particular concern is the last PM date or the next PM date. And in fact, one of my directors in South Carolina was so proud because before COVID hit, they were surveyed, their 3-year survey, and it was at one of our outside, one of our clinics. And the survey was in the clinic, and asked the nurse, how do you know that's the PM? And the nurse knew how to go into our system. We had a link right on our home page. They went right into the system. She put the number in, the data came out, and the survey. So it worked out well for us. The only part I had to knock down with not doing vision or anything like that, I had a CBET, California Department of Public Health. He's shaking his head. California Department of Public Health came in to do their survey, and yeah, you're not used to sick. What do you mean you're not used to sick? You got that sick. And this lady surveys our facilities in most of Southern California, so it's the same survey that most of our facilities have. Nancy, imagine that, you know, I'm on the first name basis for Nancy. Because I said to her, Nancy, can you show me in CBET where I gotta have a sticker on it? She goes, it doesn't matter, it's Nancy requirement. I said, now Nancy, come on. So anyway, we've gotten around that. You know, we've gone through other CBET surveys without a problem. But anyway, that's a long-winded explanation some teamwork. Continuing regulatory, I talked about AEM. If you're not doing it, you're really doing you and your employer a disservice. This is some of the language associated with the CMS guidelines, requirements for AEM, and it talks a little bit about AEM and what you have to do. Go through that slide. For those folks that are in-house or third party, AEM, got an AEM program? Right to repair. Dave's given a much more robust program than my little cursory overview. So there are continuing discussions among stakeholders. So there's a program called the Medical Device Servicing Collaborative Community, and it's really an impetus from the FDA. And if you recall, 2018, that meeting in November 2018. Medical Device Servicing Collaborative Community, MDSCC, Medical Device Servicing Collaborative Community. Yes, because you got to go to Dave's presentation. And the reason why, and that first bullet point there, among several stakeholders. So, AID's in that meeting, the FDA is in that meeting, health delivery organizations are in that meeting, third parties are in that meeting, Dave's part of that meeting. Okay. So there's a lot of stakeholders that are trying to help the FDA and the medical community come out with a solution that makes everybody happy from the perspective of how medical devices are being serviced. Okay. So the OEMs are saying, and I'm going to speak from my perspective on the in-house, that we're not doing it right, we don't know, we're doing it wrong, we're putting patients at risk. But this community is trying to bridge those gaps, and for us to come together. Dave and I are on a committee about benchmarking, the presentation on benchmarking. So we're trying to come up with a way to standardize our data so the OEMs are reporting similar things that we're reporting as well, so that the FDA can be it's a more objective evaluation of the service quality versus a subjective measurement of service quality. The OEMs put together, and that's why this all started, was the OEMs went to the FDA, they wanted the FDA to regulate us being, again, we'll see from the in-house perspective, applies to third party or anybody else that might serve the medical devices. They came at the FDA and wanted to regulate. They're saying that, hey, they have an FDA GMP compliance requirements, things like that. My report back to that is, I have CMS requirements, I have state requirements, I have a whole lot of different ADB, CLIA, you name it. I have a lot of requirements and regulatory obligations I have that you don't have. So, FDA is still supporting this process. Again, they are very much involved. We need to be involved, and like I said, at the state levels. Whatever state you're in, Colorado, just take a peek and see what they're up to and see what kind of legislation might be through that can help us all out. All right. Letitia knows. So it's great that you're involved and the team here at UC Health is involved. Benchmarking efforts to try and level playing field. Attendees conference later this afternoon, you'll get some more. Here's one thing that frustrates me about my peers is their ability to take on risks. Well, that is such a core component of who we are and what we do as HCM professionals. Is our ability to take on and tolerate risk and decide to use a third party providing parts and services or parts, like training and education. Jim sitting right there in front of us. I'm using an ADB, and we use ADB, one of those providers. But it is so important to be able to accept risk, to manage risk, and to develop, to get your point earlier, that relationship. Because you know what? The OEM messes up, third parties mess up, and it's how they respond. Heck, we mess up. It's how we respond to mistakes or problems that we had from time to time. You got to make sure that they're there behind it. You know, when the stuff hits the fan and you turn around, they're standing right behind you to support you. And that's with anything. OEM, a third party, it's so important to be able to utilize these folks, minimize your risk, minimize your costs, provide a better quality product for your ultrasound tech, your rad tech, your laboratory tech. So, you know, fear. We're all fearful. Oh my gosh, I'll lose my job. False evidence appearing real. Two means forget everything and run, or face everything and run. So I like to think my team faces everything and rises up. Imaging is, Jim said, imaging is a great target. You're not doing imaging or developing your imaging expertise. It really is a lot of money involved in that for service parts, and the ability to get involved in that is so important. Get involved in, I heard the last name, linear accelerators, TTMR. You can do that in-house. Find the right partner. Don't be afraid of that. Linear accelerators is, here's a great story. Even if you don't really target. So, Barry bought Accurate. Accurate is a cyber knife. You ever heard of cyber? It's a robotic cancer treatment tool. We're paying $495,000 a year for service. $495,000 a year. And just kept on chipping at it, working with that. And finally, we said, okay, you know what? We'll train 2 of your engineers, which is no cost. And they reduce the service contract to $275,000. Win-win. So we were the first thing. We got stuck down the line. We called the lady parts.
So you got shared service?
It was a shared service contract. Yeah. And we had a tomotherapy system as well. So tomotherapy is a CT married to a linear accelerator. And we were one of the early adopters of that from what we used to call tomotherapy. But so the guys up at the University of Wisconsin put that product together, and when we bought our first tomotherapy system, there was a lot of off-the-shelf routers, things like that. They were talking to computers about that. A lot of time and effort of service work we did with that system. But we also, same thing, shared service contract with that organization, same thing, our work. So don't be afraid to take on risks. You don't get anesthesia. Every one of our facilities is doing anesthesia. So it's not a boogeyman. Target an opportunity, target it. And I know early on in my career, the way I was successful in turning our radiology director was they had a room in the ER that was down for 32 days. And it was older machine, all effective yoga. It was a seamless system. But it was in order to now it's not. I would say, hey, we look at that system. And you take it very heavy. They take it very heavy. We had a third party, Ed Raven again, across the river, that we do with that. We called Ed Raven again. You can look at this. Ed had that system up and running in no time. Less than 24 hours, we had the system up and running. We didn't do the work, it happened, but we knew the solution to get the work done. And from then on, that started my career in imaging. And to this day, I try to do as much imaging as I can, meeting my team. I try to take that whole book there. You know, that service engineer that comes in from Phillips or Siemens, GE, they put their clothes on the same way you do every morning. They're not magic. And you know what makes us, in my opinion, makes us a little bit better than them? It's because of how rounded we are as professionals. We see so much. Our troubleshooting skills are so much, in my opinion, better than the OEM person that comes in. The reason why people say, but I know what the OEM is for. Again, a lot of folks come right out of college and they train them up on their product. So the only thing that person, I'm not disrespecting that person, the only thing they know is that Phillips CT scanner, or that GE PET system, or that. For them, you know, our skill set of our team is so much more advanced and progressive, where they can start to troubleshoot and think outside the box, where, goodness gracious, if they can't figure it out, they got to go to subject matter experts back in the home office and wait for that call to happen and try to get it fixed with that subject matter expert over the phone. Don't get me wrong, we have subject matter experts in our program as well, and we use our Zoom meet so that, you know, if the tech is stuck, they can use their PC and hold it up to what they're working on, and the subject matter expert in Texas to help the guy in Vegas to figure it out. So we certainly use that, but you know, I just think our skill sets are so much more advanced than we have. So, you know, look for those dog systems that might be difficult and volunteer to try and make things and go after it.
And refuse to work on them. Also, they can't work on. You know, trained on.
You know why they don't? Because those people were making a lot of money. So they, when the rip came, they ripped those guys and gals with a lot of experience and wanted to bring those folks up from the university and pay them, you know, $35,000 a year, give them a car and drive around. Now that's how I hired my first lead accelerator person. Eddie Whittle, Johnny Whittle. And, you know, he told me, he said, Chris, you know, on a Friday night, I had dinner planned with my wife. You know, it's 4:30 in the afternoon. She's getting off work at 5. We got, you know, we're going to go to our favorite dinner place. And the phone rings. And Johnny's on call. And Johnny's got to drive 6 hours to Wichita to go to service. Go service the linear Delaware. He said, no, there's times like that that just got tired of it all. But laugh at it. They're working all day long. They're on call. They get a call at 8 o'clock in the evening. They go out to fix the machine at 8 o'clock in the evening. Got home at 2:30 in the morning. And guess what? The next morning, you got to be up and ready to go. You got you already scheduled it. Such and such members, and then you together that whole system. Just tired. They just run a ragged, and they do make overtime. So, you know, the person will hear, well, it can be expensive. I think there's a happy medium. I think they're willing to give up a little bit of that salary for quality of life. Yeah. So we've been successful from that perspective. Getting folks on board like that. The last thing with regard to risk, self-insurance. Talking to your administration about self-insurance. Okay? It'd be a hard conversation. Because you're going to have, when you want to take something, for instance, detect, flat detect. You know, you have all these service contracts on these flat detectors because you're worried about drop. And luckily, the organization right now had the CFO down in Florida, who I was able to talk with and convince based upon the data that we showed them, because we already had some flat detectors in that facility down in Florida, at the Water Hospital, and showed that, you know what, we had these insurance policies on some of these detectors, but we never dropped it. Our staff is handling it as well. And the cost to cover over their life, 3 or 5 year range, the return of the investment. We took us up on that, and so far we're bringing down the number. So we have other facilities where we weren't successful. We didn't want to cover against some facility. You can't make that financial evaluation. And I'm going to talk about a document that I perform, a financial document that I use, decide whether or not it makes sense to either buy a service contract or put it in a pool. What do I mean? What do I mean by pool? So in my organization, like I said, I have 28 hospitals. So if they have a detector and we want to put it in the pool, we don't make them stop buying a service contract price. Right? We take that money that they were putting in the service contract and we put it into the pool. Okay, so in the event that there's a drop, we have money to cover the cost of the drop. If there's money left in the pool at the end of the year, we look at that pool, we determine what percentage of that we want to keep in the pool, carry over to the next fiscal year, and then what financial incentive we provide back. So, correct. But our finance team has figured out a way to carry within the law, and that's correct. But they're the financial wizards. I don't. So I'm just a file maker. But yet they figured out how to do that. And I mentioned that my first entry into it was most recently was the automated line. You know, so we don't have automated chemistry lines. So they would always have an issue with the automated line. We were spending $85,000 to do a certain contract, the automated line. And you know what? My technician that was our lab guy, he would pay attention. He would pay attention when the service engineer came in. And it was always these gates. You know, there don't seem to be a problem with the gates that you pull the sample into analyze it to use. They found out that it looked like most of the time it's just the optical sensor dirty. So we bought a set. And the first time that one of these things worked, we just put the optical sensor in the shop. When we cleaned it, we cleaned the sensor, and then during the lull, we took it back upstairs. We didn't do that. And you know, we dropped that $85,000 contract. So that worked out well. And we just kept on growing. Because once they saw that we could handle that and not slow, because they don't want to slow down. A gazillion samples come in the morning, you know, especially in the morning, as orders come in. So they just don't want to slow it down. And now they realize that, hey, I have a person downstairs that can be up in less than 5 minutes, and we can get it back up. Same with the chemistry analyzers. We do have some partner agreements on that type of stuff where we can do first look. In fact, I tell all my members when we are buying the service, I do the full service contract. My technician still going to go in there and look at it. When the call comes in, we're not going to just pick up the phone and place the service call. If we can get it back up and running in no time, and it's not impactful. surgery schedule, a lab schedule, process, so we're gonna do it. And we make that. The only thing that robotic surgery system, that's the one we haven't made progress. One of these days, I just have to get my supply chain team on board the next time they contract. So vendor relationships, we talked a little bit about that. One of the bullet points I put up here is cheap prices. It's the other thing that drives me crazy about my peers. Is a lot of them just want cheap, right? Well, I like to put it this way. I want the most competitive price at the highest quality. So one of the things that I do in my program is we vet vendors, third-party vendors in the vendor. I made a visit to AUE, to look at their operation. We send $40,000 endoscope out to Joe the Rabbit. What's his insurance look like? What would happen if the scope came back and the physician used it and a piece would go off inside the bowel? You gotta be cautious about it. Not that it doesn't happen, but you gotta know who you're in. Like a scope vendor that we do. I go in, I make a visit, or one of my directors down that area, down in Texas, I had a director, it took much more than me traveling down there. He went into the facility. But what I do is I talk to the employees. The vendor's going to want to take me in. Look at all this cool stuff. And maybe this is the back room. And I talk to the people that are doing the work. Because if they're miserable, I don't want to work with that. Because those people doing the repair are miserable people or are not very unhappy because sleep traffic, horrible organizations that just go, who cares about quality? You're going to know from them. So that's how I vet my vendors. I try to, if you're able to do that, sometimes the vendor will provide expenses to go down and move them. It's an important piece of the process. So I don't go for cheap prices. I go for lowest competitive cost at the highest quality. I think that's cheap. And sometimes it might be the cheapest vendor, but I don't want a cheap repair. It's the brand of Universal Health Services at risk. It's the brand of UC Health at risk. Because you don't want your name on the front page of Colorado Intelligentsia, or whatever the name of the newspaper is. You don't want your name on the front page. I don't want my name on the front page of a newspaper in town. So it's important that you vet your vendors properly. And I think went to CMI meeting, met this person for an ultrasound. He had a great, so he needed an scope, 5. And hey, I met this guy at CMIA last night. He's got a great deal on this ultrasound kit. And the order, because I stopped the order, I saw it. My technician spent up to 2,000. My local director spent up to 5,000. And then my regional director spent up to 8,000. That's the way I audited the drill work. So regional up to 8,000, anything over 8,000 I have to see. So this was a transducer. And it's a great deal, like $8,500. So my buyer, a couple buyers, corporate, everything goes to the corporate office. And buyers say, so-and-so out in California sent this request in, it's $8,500 for a scope like that. And we have a relationship. And, if the OEM, we have a pretty good relationship with that OEM, and the other store repair company can't get it done. Why can't we sell it today? So I looked up the address on Google Maps, right? I looked up Google Maps. It's some guy's house in California. Why not do it? Did he steal it? I don't know. Hey, I had a technician in one of my hospitals in California. Stole a Olympus Eagles. Stole it. We had it in video. And
They do it.
sell it. So, yeah, we had these robbers taken out of the zoning house, but you gotta be very, where you buy your parts from, Matt. Don't be cheap. Don't be cheap. That you're gonna come in with schools, probes, bigger media companies and stuff.
But like, you got the last 4 times, 3 folks got around.
Yeah.
So you can prove something a little bit.
Yeah. You gotta have that attitude. You gotta be monitoring, because nobody else is for your patient and your doctor. You're the only one. The doctors that are using that tool to do your patient, you gotta have their confidence in your program. Right? You're gonna go back and use the OEM because they all think that the OEM does it right. But I can show you lots of pictures of OEM service. Because at UHS 4 years ago, was an absolute company to a big, large company as like a meatball. And we came in behind them. And, the PMs, plan maintenance, no other comment. So then I come to this slide, and this slide talked about boarding technology becomes high tech. Build a nurse home. We do all our beds in the nurse call system. Maintenance handle the beds. Well, maintenance used to handle the beds. And when I asked them how much labor and how much cost that they spend doing bed maintenance, I got mockers. Nothing. They couldn't tell me. They had no idea. And most of the time now, our beds are, a lot of them have scales in them. Stretchers have scales in them. Your physician is making prescriptions regarding how much the patient weighs, right? How much of that drug is going to give that patient. The beds is a very important piece of the puzzle. So we do beds in-house. I know it sounds like a hard thing, but we do it in-house. Nurse call systems, I mean, they're IT systems. Let's face it, our nurse call systems do so much more than just nurse call. We have an alarm management system that we're connected into, right? So when the nurse or when the patient pulls the nurse call, it goes to our alarm management system. It gets triaged, like it's a bathroom alarm, or bedside alarm. It gets triaged, and it either goes to the phone of the PCA, the patient care associate, or the nurse. Like it's ice chip. If the call comes in and the nurse takes it, and the patient just wants ice chips, the nurse doesn't. That nurse can now forward that call to the PCA that's responsible for that room, and that nurse can then continue to focus on the patient that he or she is with. So the nurse call is so much more than, we send our imaging or patient monitoring stuff through there. So real-time location system, anybody have any of those? We have RTLS systems. So I'm not a big proponent of just tagging equipment. I like to tag our patients. So we're managing efficiency from the ER or the OR. We're managing the locums from the ER. We're managing our radiology. How much time are they sitting in radiology waiting for the transporter? That's RTLS. And then the last thing was that fellow from Cybernetics that was in here that sponsored this talk, we HTM, came out of my budget, to fund our cybersecurity. So I used to report to the CIO, corporate CIO. He got promoted to a senior vice president level. He now has, a much larger responsibility. They hired another CIO, but I don't report to the CIO. I still report to my old boss, who's now a senior vice president. But we are so connected to hip with our IT people. I'm sure, hopefully, most of you are. I know you have such a report to the CIO. Cybersecurity. We had a whole security team in our IT side, but in the first presentation, I don't know if anybody's in that, as was talked about in that presentation, the medical device side, they're not too keen on the medical device side. So that's all on our responsibility. So we came to them and said, hey, we go to the Medicaid, and we use Simply, called Simply. They're a dime a dozen now. In the beginning there were a few, and now there's probably 50. But it is a cool tool that we use, and we deploy it. It does a lot. So not only does it, as Nathan said, it sits on the network, this is in the traffic. So if somebody's trying to patient bedside monitor that has a USB connection. If somebody's plugging their phone into it, the phone has they want to charge it, and the phone is compromised, and it starts to see abnormal traffic, or it starts communicating to a different IP address outside the organization, that can be detected. And now ours is integrated to our NAC controller. So if we have to shut down a port or something like that, NAC uses the information from that tool to shut down the port. So now we also have it integrated to our AIMS. We use AIMS for CMS, So now the IT guys and gals can know at a moment's notice what it is. They know exactly, because it immediately sees the IP is connected to our database, and they can see exactly, oh, that's the Canon CT scanner in radar. So the other thing it does is utilization. So during this whole COVID crisis, part of my presentation about COVID, during this whole COVID crisis, we've made a lot of requests for pumps, we need more pumps, we need ventilators, but the pumps are connected to the network. Well, I can see how many pumps are being used at any one time through this tool, this facility tool. I can see all the pumps that are in use and being communicated over the network. So, I can tell, at one point, 85% of our devices in South Texas were in use. They were getting packaged, but there was still availability. And you know how these facilities are. The CCU doesn't want to loan it to the ED because they're never going to see it back. Especially if we're for-profit. So the budget for the CCU, they buy their infusion pumps, right? It's not like the hospital buys the infusion pumps. The CCU has to budget for one infusion pump. So the ability to want to share stress. But we were able to manage all of that for them, providing reports. How much is the support percentage?
So, to me, it sounds that you're using condition intelligence to manage places, to monitor traffic. Now, COVID, what has happened is most patients are at home, they come to the hospital in a very sick.
Yeah.
When they go home, they're getting these devices, the monitors, these providers go out to the hospital. These patients, they check their vitals not at a given point at the last time. How can you use the same system to ensure the integrity of this streaming providers from the cloud of this other country? To ensure that the organization is safe.
Yeah, that's true. And now this tool doesn't look at any of those, like, the cloud protection is what, because the device is to a cloud application, and it's not to our server back on the site, right? All we're getting from the cloud application is data, information, to the blood pressure, to the heart rate, whatever is necessary. So from a security perspective, that data is secure. It's really the vendor that you're using for that application. You have to depend on their security. The case, communication, and there are a lot of times that use it, cell phone networks, and things like that, this day and age. So, so we have that tool. It's a great tool. You know, that's something that you can, utilization. We know how much our CT, MRs are scanning. We know what kind of procedures they're doing on that. We had a facility that wanted to buy a new CT scanner, and we looked at their current one, and it was 37% utilization. We got information from the administration. The question: why do we do? What's going to change if you buy a new CT scanner? If we spend $800,000 on a new CT scanner, what's going to change? How do you get? Because 37% utilization is going to pay off $800,000 back. So, you know, we're getting data like that capital planning. Really cool tool. Data security, it's IT's responsibility. Wrong. We all have it. So the nurse that plugs his phone into the bedside monitor, we have to be vigilant, either deactivate those USB ports or use physical controls, you know, physically disable those USB ports. But these are all the value-added things that you can use for your organization. Cybersecurity is such an integral piece of, if you're, number one, you get your name in the paper again, because you breach. You're going to pay a hefty fine in the Office of Civil Rights, right? You're going to fine you big time. You don't want to get that. So if you have devices with USB ports, and we all do, make sure you're managing those. Make sure, or that you're talking to your IT team and you're strategizing with your IT team how to segment them so that they're not able to do as much damage if something happens locally in that box. We know how many HTM devices touch a network, right? Listening. We have that tool listening. We have our IP addresses in our CMS system. We have software. That's the other thing that tool does, is it knows what operating system you're using, right? It gives you that information. It knows what version of that operating system you're on. So all that information comes through that IoT tool. And then this goes so high up, you know, board of directors get involved because the Office of Civil Rights is the folks that penalize you for a breach of data. I told you we integrate our CMS product with this tool so that now our IT team knows what device. You know what else we recently did when we took is our CMS tool. I told you it's games. So one of the things I was telling Ryan last night, one of the things that our operating room does is when they bring a patient in for surgery, they document every device that's used on that patient for the surgery. What ESU is being used, what anesthesia machine is being used, all of that information is documented and put into our CERN EMR. Well, initially they were factoring in that information, manually type it into the keyboard from the workstation on wheels, right? The circular nurse does that. And we have this huge database with all that equipment that's in the room, right? Right now, maybe patient device identification anyway for sure, right? So our patient bedside monitor has a barcoded label on it, and when the nurse that's in surgery or in the ICU has to marry up that monitor to that patient. So the data that comes into the EMR flow sheet to that patient, they scan the barcode, they scan the patient's wristband, scan the barcode, and that connects that patient to that monitor. We thought HDM, we're watching them write all this stuff in. We're watching them type this stuff in. Well, why can't we give them use of our database? Well, initially what we did was give them a copy of our database. And so they would know all the surgical devices that are in that room. They would just have to write down type in the control number of the device for that room. Well, Ames has an open API, right? We can just use an open API with Cerner. Well, Cerner integrated with us in India. Cerner said, yeah, we'll do that. So we got Cerner and Phoenix Data Systems, my HTM, and also my UHS ITT, who does all the integration. Within a few weeks, we have now a live database. They do the same thing with patients like patient device identification. When they're in that section of the Cerner flow chart where they're documenting all the devices that are used, all they do is use that same scanner, go over to the device, bleep, 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 and it just populates each line item in that Cerner section with the device that's being scanned. So now it's real time. Before, we would have to get these periodic updates so that equipment moves and it gets retired and new stuff comes in, and they were having trouble. Hey, you know what? That one's not in the inventory. Can you send us a little inventory? And so it was kind of self-serving a little bit, but also all we hear now, they think so what actually is all of that typing in of medical devices. So another value that actually happened right at the beginning of COVID that API work. We also use all of our technicians make purchase order requests through the Ames application. So they make the request with Ames, so now it's tied to the device. Now how much exactly what's spending on that Epic ultrasound system. And then maybe it's flagged for approval, right? There's a certain financial threshold. My buyer then gets it, and the buyer can, right, so we put that buyer in the middle of the process. When the buyer sees it, the buyer can do one of two things. They can continue with that source of okay. Like if they need a Phillips power supply, they can buy it from Phillips, right? The buyer can buy that power. But the buyer sees it and says, well, I have another partner that we source that from. Let me call that organization and see what kind of price I can get. And the buyer then is allowed to flip the provider for that part. And then once that buyer takes care of that process, it goes back through the McKesson. Goes back through McKesson, back to the Ames, that the purchase order is issued. The purchase order is that part. Because we see multidisciplinary HCM plays a prominent role. Low cost of managing information identifying. So our solution is a low cost solution. At 20-something facility that we're running, or 18 or something like that. I mean, if it's not an expensive solution, the IoT, IoT device, talk about MS. Oh my gosh, I'm trying to remember everything I was talking about. The sheets for the IT to make sure that it's MDS squared. Right? Medical device.
MDS, oh, medical device.
Yeah. Yes. So that's all in that product, that similar product. Recalls are also used. We use a company called Managed Recall, but we also get that information through the solution. And then the last part of my presentation, my final slide, before we go to more questions, is the value proposition. Plan, plan, plan. Put together a plan. If you don't have a plan, then you plan to fail. I use a document called pro forma to decide if we're going to service in-house or we're going to service for the service contract. And that pro forma, you're going to collect a bunch of information that talks about what the service contract cost is, what the service school is, technical service school. You look at the history of the repair of that truck, how many parts have you purchased, what the cost of the parts. All that is entered into the pro forma. And it really gives you a snapshot. Does it make more sense to service it in-house? Or does it make more sense to buy a or perhaps a shared service? And if anybody wants a copy of that document, I didn't print anything out with this whole COVID. I was afraid of how much I could hand it out. If anybody wants that capital planning sheet, if you want a copy of my capital planning sheet, I'll be happy to share that. And I have those cards if you want to share your information with me, that's fine. But communicate. Once you come up with a plan, make sure you're communicating to your administration. I'm always crazy about showing the value of HCM, what we do in-house for our company. Because, they're getting knocked up all the time. Joe Ragman coming in, some insurance company, hey, you know what? We'll take all your service contracts, we'll put them in this insurance program, and you'll save a ton of money. Has anybody had that insurance program? So it's a nightmare. You claim you have something to claim, you didn't send it timely, or you missed information. The administrative part of that, and sometimes they want you to use a certain vendor. It's Joe the Ragman, not your dead, doesn't have a whole lot of experience, or who they're sending in doesn't have a lot of experience. It's problematic. So I'm always crazy about that type of opportunity. Sometimes I have it on the door. I want to make sure that my administration understands the value of we're delivering on a daily basis. I know, Mike Nelson, who my senior VP that I report to, when I told him about the API with surgery devices, anybody do that? I don't know. I think the life of our nurses goes up to the airport so much easier. I don't know. I think the guy I reported to was, I don't know how he left it, so into everything. I was so respectful because he knew a lot about HCM. He came from North Carolina, Carolina. He just so engaged in what we're doing. Whatever, all of it. So I'm very blessed. Any questions? As I see we're bumping up against noon time. There's my contact information. Like I said, if you want me to send you, I'll share everything. I'm not shy about sharing data or whatever information you need. Feel free to reach out.